request the speakers to come on the stage, please, for discussion. And may I invite Dr. Sanjay Kumar and Dr. Anup Agarwal as panelists for discussion. Kindly come and occupy the seats, please. So as they are occupying the seats, any questions from the delegates on all the talks? Any question to Dr. Unmesh Chakravarti? Yes, please.
So the fixed spinopelvic deformities, they are the more challenging ones, and usually you will have to a large extent. So it's basically the pelvic orientation. So usually if you see these Angstborn patients, they have more of a kyphosis. So once you have a kyphosis, the pelvis is tilted in the front, and your acetabulum is kind of more open. And if they have got a more flat back, then the spine is extended, then the acetabulum is more open, and you have to increase the anteversion.
Yeah, so Unmesh, very nice talk. There are two things I wanted to bring to your notice. One is this, since we are on this topic, see in Angstborn it's very difficult to get the spinopelvic X-rays done, both sitting and standing. Anil Oman also has tried it, and normally they are stuck sitting mostly, around 70 to 80% time, but they are stuck standing also. So what's the difference between these? Stuck sitting means the pelvis is like this, so you need to reduce the anteversion. Stuck standing it's like that. So, if you can figure that out by preoperative X-rays, then you can manipulate your cup. And dislocations normally don't occur very easily in Angstborn. So everybody who has done it will say that, so you need to be careful. If it's stuck sitting, just decrease the anteversion a little bit, so that helps. The other point I wanted to bring out was, I saw in your video that you remove the osteophytes and everything before putting in the cup. Yeah, so we normally do is we put in the cup and then we take out all the osteophytes. So, we find it to be much safer that way around. So the cup is the cup is there. Rather than marking anything, we just put in the real cup, anchor it with the screws if required, and then we remove the osteophytes. And again, you need to be careful. Sometimes, especially the anterior part is very sclerotic. So you need to have very good osteotomes while removing the cup. And the third thing is that, they are very osteoporotic also. So the only acetabular fractures, intraop acetabular fractures, which we have had over so many years are only in Angstborn, right? So you need to be careful when you are, putting in your cup.
Thanks, Vijay. I think
one thing I want to add, you can pass a pin.
One more question, sir.
So how do you quantify? Because I think even with these X-rays...
Let's take the mic, dear. We can go to the mic, Unmesh. We can go to the mic, sorry, for you to be audible.
So, how do you quantify with X-rays? I believe that CT gives a better orientation of...
I think Anil Oman has already published. It's quite a cited paper. Anil Oman has already published on Angstborn and how do you do the spinopelvic, and he has found around 70 or 80% of patients are stuck sitting. So the best is to, if you have a EOS. We have EOS. EOS is a machine which is a standardized machine which gives you all these angles and everything. Otherwise, you can get a spinopelvic X-ray that's right from the L2, L3 level till till the pubis, and the only problem is mostly the patients are not able to, because of the fixed spine and hardly any mobility, they are not able, you don't get perfect views.
Yeah, because a supine CT and a dynamic X-ray are different.
So just to simplify for the delegates, right? We all understand as a faculty. So what discussion is going on to get an X-ray done of the lumbar spine, standing and sitting position? There's a lot of jargon, stuck sitting, stuck standing. For a common person, it's very, very difficult to comprehend. Just to simplify, very, very simple, in majority of patients, the so-called stuck sitting, or to simplify it, there is less lordosis. They tend to become kyphotic. If there is less lordosis, you put less anteversion. Very, very simple. If it is more lordosis, you put more anteversion. Just simplify that. And you can further go ahead. No issue at all. Just to simplify the delegates.
So another problem, like you all are doing, if it is bilateral and abduction deformity, fixed abduction deformity, and you are posterior surgeon, then how to make the position?
There's a question I've written for guidance from Dr.
So
Unmesh.
we have done few of these. So, now we do it with the DAA. So, but before, when we were not doing DAA, so the easiest thing was, what we found was that you have to go interior by the small Smith-Peterson approach, do an osteotomy, and then turn the patient and do the hip on that side, on the other side. Because then you can position the patient, because one side, and we normally do them bilateral simultaneously, at the same sitting, not one by one. So that is one way to do it. And I think, the next session is about DA. DA is the best approach for this. Or you can also, the only problem with these abducted hips is that it's not possible to, position them laterally.
That's right.
That is the big, so one side you have to do a neck osteotomy or, or do an anterior approach and do it.
But for a person who is not doing DA, you are
Yeah.
you are an institutional
No.
person.
I'm not saying that, before we were doing DA, then also what we used to do is we used to go anteriorly in the supine position, the lower limb of the Smith-Peterson approach, cut the neck. So one side is now, we never used to do THR. So then position the patient, the other side is still high, but you can position the patient and then go ahead and do it.
So in case
Posterior approach.
we are not doing an osteotomy and placing the patient, somehow positioning the patient, the biggest problem we'll face is for anteversion, etc. How to do that? So any tips from the panelist?
Better decision to be taken per-operatively. After cutting the neck, you can pass a pin and take the anterior position and lateral view and then C-arm. You can decide the correct anteversion or inclination.
So the question going on, quickly we'll answer because the time is running out. How to position the patient? In a case which a patient has a bilateral abduction, flexion, acceleration deformity, how to position the patient? That's the question. Any tips from the panelist?
So I do the same, osteotomy.
Opposite side.
Yeah, opposite side.
So
learn from
suppose
the
we are
Rajesh
going to
Malhotra,
do
sir.
THR today on the right side, you do osteotomy on the left side, make it down and do THR on the right. That's the suggestion? So we can still do, if you can position the patient, whatever it is, oblique, you put padding, etc. And you should know how to calculate your anteversion, isn't it? So that's the problem.
On the padding, they keep on rolling actually.
Long time back, around 10 or 12 years back, the other side neck gets fractured.
Can be used.
So sometimes that happens. So
I
you have to
think
be
if
very careful. Yeah.
See, anything can happen if you're not careful.
But it's very easy to do. So, and
You can do Harding
I don't
approach
think,
on traction
before-
table for such
Let's
patients.
speak. Yeah, please.
You can do Harding approach on traction table for such patients in supine position.
There are many ways of doing it. Those who are doing it the posterior approach, I am a posterior approach surgeon. I have bilateral hip with fixed flexion, abduction, acceleration, deformity. How do I do? That's the question.
Before
Is there a way
DA, I think there was a modified Muller approach.
We can doing with direct
anterolateral.
anterior approach in supine position also.
That's okay. We are talking
no need of
position.
lateral position in this.
Dr.
Many
Sanjeev was about to tell us a
many
tip
surgeon
of
doing
how to do it.
nowadays.
So I think you can do any way, whichever you like, actually, and whatever is you are comfortable with your experience. One, two, if not, you may call your colleague who is good with any kind of entry approach except DA, which could be sometimes very difficult. Though in our country we are talking DA nowadays for every difficult cases, but believe me or not, there are huge number of complications. So you should not try DA, especially in enclosing, to begin with. But you can have other kind of anterolateral and other approaches, which was quite common done for non-orthoplastic cases by all of us. And you can try that or call somebody to help. I think it is much better idea.
And intraoperatively, whatever the position of pelvis, TAL gives you a good guidance for anteversion. The problem you face is in coronal plane, whether to go anteriorly or posteriorly, are you too much anterior or too posterior in a fused hip where there is no external margin visible. That becomes difficult. Even image will not help at that stage.
So the other problem with the DA is that you require those special instrumentation, offset reamers, and that is not always available in the setups, or the traction table with that leg attachment.
No, I think, see, if you are a DA surgeon, then only you can do it. Otherwise, it is not advisable at all, as Sanjeev has also pointed out, to start with it. But what we used to do before we started doing DA was that we used to go anteriorly, do the osteotomy, and then position the patient that way around. Or else you can even do the modified Harding on the lateral approach in a supine position, as has been described. Germany people do it in supine position, not lateral position.
There's a question from the delegate. Yes, please. There's a mic. You can. I will speak loudly. It doesn't matter.
Regarding failed fixation in total hip arthroplasty, the trochanter has not united. Implant is there already. We are more comfortable with doing a hemiarthroplasty. What are your reservations or extra precaution you will take so that these total hips, along with the femoral reconstruction, don't dislocate? There are very high propensity of these total hips to get dislocated. So, an elderly patient, what are your reservations or your precautions you take to avoid dislocation post-op?
See, the dislocation rates are high. It's very true. But as far as trochanteric non-union is concerned, one must do osseous reconstruction with the help of cable or a plate. That will still further prevent the dislocations. Other thing, if not possible, at least do some wirings with the non-absorbable sutures you can use with bone grafting.
Anybody using DM cups in these cases?
Pardon?
Dual mobility cups in these cases?
Dual mobility is one of the option,
Yes.
but sometimes it's not very cost effective. Second thing is these bones are very porotic also in SWR side, and not all the companies are having dual mobility with the screws available, and they are quite a big socket like a BHR, so you can perforate even the SWR. So you have to be very careful using a dual mobility. Dual mobility indication is usually when the socket is very small and you don't have a 22 head which is not available, 40 sockets, then the dual mobility works in our hands much
So
better.
the answer is try to restore abductors. I don't think many of us are using plates now. Try to restore abductors the best way you can by wire, tension band wiring, Ethibond, whatever. And if you're still in doubt, one option available is dual mobility cup. But the caution is what he's saying, if the bone is quite osteoporotic, you have to use the modular one with the screws, etc. So these are two options to prevent dislocations.
And you have to be also very careful with your soft tissue dissection. As long as your trochanteric is continuity with the soft tissue versus lateralis, probably it will work. You have to just keep the tension of the abductors correct there. I think it will work.
Very true.
Dr. Sanjeev? One thing I've had to make into notice that the piriformis is a very good external rotator. And this scenario, you just preserve the piriformis tendon, and it will definitely check your dislocation in the future. And of course, dual mobility is a good idea for that
The
one.
discussion is on the solution. We all know the problem.
No, that is the solution. That you have to preserve the piriformis. You not cut the piriformis. You go through the trochanteric window and then you do the replacement.
So that's
You not cut the rotators and all.
So very important, you should try to go through the fracture,
Exactly.
not cut in a regular THR.
You wanted to add something?
Yeah, in elderly fracture neck femur, above 70, we go for bipolar, modular bipolar. Is there any harm in doing just modular bipolar in such cases if acetabulum is okay?
Yeah,
In
so if they're
field?
very, very old and like just, housebound, just doing the toilet and
No, but in
bed,
elderly
it's
fracture
fine.
neck femur, we are mostly doing.
So the
modular
question
bipolar.
is, can we
We're
do
not going for-
bipolar?
No. If they are, see the problem and the concern is if they are too active, they will have an acetabular pain. So if they are active, you have to do a THR. Otherwise,
No,
if
but
the
then
patient is
for every neck femur, you should do THR only.
No, it is not must. It is not must.
No, it is not
It is
must, but in like long-standing non-union fractures, the patient is not weight-bearing for quite some time, so the cartilage is always at risk. So the chances of chondrolysis are very high. So it is advisable to do total hip rather than bipolar. But when the size is small, then it is sometimes you have to decide whether to go for small head hip, total hip, or the bipolar. So it is better to go for large head, total hip, or the bipolar, because the chondrolysis rates are very high and it may become painful with bipolar.
So,
See, it is not necessary to use the long stem also, because not all the long stem sizes fits with our canal. These are again an osteoporotic bone. We are forgetting the technique of doing a cemented stem. So these are porotic bone. If you put a tight fit long stem or distal fitting stem, you have a fracture, you have kind of a bowing. So try to also learn and do a cemented stem with even a bipolar. It will not sink also, and it gives good stability and faster mobilization.
So the answer was that for community ambulators, we prefer hip replacement. For those who are household ambulators or an old person, infirm, morbid, we think of bipolar. That was the consensus here. Any question next question you want to ask?
A question for Sanjeev. Dr. Sanjeev, you showed subtrochanteric osteotomy. Means if you can clarify to everybody that, if you're doing a subtrochanteric osteotomy, you prepare your stem first and then do the osteotomy, or you do the osteotomy, do the acetabulum, and then you go for the...
See, prepare the stem would be difficult, because if you are using those acerome stem, right? So you can do both the ways, but you can see the canal first, definitely what kind of stem size is going, okay? And you can do both the ways, but I would rather do a trochanteric osteotomy and do a stem.
Yeah, but what we do, and I think which most people, the accepted thing with the SROM is that you prepare the stem first, prepare the sleeve, prepare the stem, do an osteotomy, take out the stem.
Yeah,
Sleeve
that's
is
correct.
there
That's
all-
correct. That's what I'm also
because
saying it.
It's much easier to prepare the stem with the sleeve when you have the whole, as one piece, rather than, two pieces. So
No,
this is
no.
what we found.
You're right. What I'm trying to say, I'm not putting the stem in. Definitely, you have to prepare the proximal part of the sleeve. You're doing in a stem.
Yeah, proximal part and the
Yes.
stem, and then take it out.
Canal size you
Yeah,
see,
yeah,
and then
you
accordingly
take it
use
out,
the.
do the
Yeah,
osteotomy, and then
yeah,
you
that's
put
correct.
it on. Yeah.
Completely.
Dr. Sanjeev, for the guidance of delegates, can we use a cemented stem with the subtrochanteric osteotomy?
I have not done it actually because you need to have a proximal fit stem there, and SROM was one of the uncemented stem. But in the past, I'm sure that with the Chanley old kind of thing, people have done it.
There are cases, there are literature that you can use
Used to
cemented
be
stem.
Chanley CRH stem used to come, and people used to do that.
Do we have time? The organizers permit us time for discussion to continue?
Last question, sir.
1 minute permitted. Yes, please.
What is the real indication of high hip center? You showed the subtrochanteric osteotomy, and what is exactly the indication of high hip center?
You keep the high hip center
He
in
told.
kind of grade 2 hip, possibly where you can have a good bone stock. You can
He
put
is
it.
asking definition. See,
Yeah.
if you go literature, up to 22 millimeter above the normal rotation of center of rotation is considered up to
Yeah.
22 millimeter as high hip center.
Now, if you don't have an access to SROM type of hip, then there is no option left but to go for this
The
subtrochanteric
moment your
osteotomy.
lesser trochanter goes above the teardrop, I think it's called as a high hip.
Does that answer your question? Okay. So, yeah, please. Last year.
One in old intertrochanteric fractures, usually the limb is in the external rotation. So if you put your implant femur, then it tends to dislocate in bipolars. And if we do THR, then usually we are able to locate it. Should we put our stem into retroversion to counter that external rotation?
No. So that's a tendency because it is ununited. You don't have to change anything in that. The standard thing you do, you have been in routine THR, you do that. You don't have to put retroversion, etc. No, not required.
If we are doing it from the anterior side, then it tends to always come out.
You don't have to change the version for that.
Sir, it's
One
the
thing.
non-union which is causing the external rotation. It's all in one unit. Then the internal rotators will pull it back.
Yeah, and the second thing is regarding the high hip center and the subtrocosteotomy. Are there any indications for the high hip center, or we should always do and try to put it at the original position?
Vijay,
So in Crow type 2 and 3, you can accept a high hip center. Crow type 4 and 1. 1, of course, it's not much high. 4, the best bone is at the native vestibulum. 2 and 3, you can accept a high hip center. But there again, as Dr. Niroda has also pointed out, you should not be more than 15 to 20 mm from the original center of rotation, right? And it should not be lateralized. That is the biggest. It's not the up. If it is lateralized, then it's a big problem. So, it should never be lateralized. It can go up around 20 mm also.
so going by literature exactly, if you ask, reviews 16 millimeter is mentioned.
Yeah.
Up to 16 millimeter, you can easily go. There is no difference in longevity or revision rate. But the only word of caution Dr. Vijay said, your cup should not be up and lateral. It should be up and medial.
Up. And another thing, you have to see the literature also. If you see papers, some people describe center of rotation, some people describe teardrop. So this 15 mm or 18 mm is from the center of rotation, not the teardrop.
Center of rotation,
Yeah.
the description
teardrop
is
figure is
22 to
13.
28 millimeter,
Yeah.
but best is the 20 millimeter.
Yeah, 20.
So one question.
So can we continue? Shall we stop?
So just one extension of this question is that if the females are small who have a 40 cup, so does that 16, 18 or 20 mm still stand? Because I think that is all right for larger European Western populations who have larger acetabulum. When we're talking about smaller acetabulums in Indian females, maybe a 40 or maybe 38 or a 42, does that 16, 18 mm high hip center still stand true?
So that is a generalized statement. There is a separate study for Japanese with slightly lesser. So that's true. It will be a few millimeter different, but overall speaking, up to 16 millimeter, what he says 20 millimeter is acceptable. No issue. I think we should stop the session now.
Right, sir.
Thank you very much,
Thank you.
chairpersons. Thank you very much, panelists and speakers, for this absorbing
Thank
session.
you,
Thanks a
speakers
lot.
and panelists. The certificate for the all the faculties are available outside whenever they want.